The content of this podcast is based on medical fact and evidence-based practice from credible authoritative sources, but is not a substitute for your institution's policies, procedures, common sense, or good judgment. The views and opinions are those of Eric Bauer and FlightBridgeED in their entirety.
Hey everybody, Eric back with you. In today's podcast, I want to go over an RCT on ketamine called the Prehospital Ketamine Use of Rapid Sequence Intubation are high doses associated with adverse events. Obviously, we have seen a huge influx in ketamine use starting probably 2014, 2015, and there has been a lot of progress in understanding this medication. I think from my standpoint, this is the first true RCT that I've seen. So this was a multi-site retrospective study looking specifically at adult patients undergoing RSI with IV ketamine. There was actually two subject groups. The first group was going to be any medication use that was less than or equal to 2 milligrams per kilo. The second group was greater than 2 milligrams per kilo, and that average was right around 3 milligrams per kilo for that induction dose, again, IV ketamine in RSI. The area that was looked at was ground and air medical environments between January 2014 and July of 2019. When we look at the literature associated with ketamine, we know that the literature amount is very small when we look at doses exceeding 2 milligrams per kilo. I was actually a little bit surprised. Again, it's all about your perspective. It's understanding really what not only you're doing, but what other programs, what areas of the country are doing things a little bit differently. And I think predominantly what I've seen traveling around the world is that most places do not exceed 2 milligrams per kilo. And I think that's where I was a little bit surprised in that rapid sequence intubation setting. So what were the findings? Really, the findings showed that the increase in dosing greater than 2 milligrams per kilo actually did show a higher incidence of hypotension and hypoxia in those patients. So why is that? Is that giving us any information that we don't already know? I think we have talked about this in other podcasts. There was some observational studies done by Air Methods, and I've highlighted those in other podcasts that Dave Olvera and Dan Davis have conducted, where they did actually see an incidence, increased incidence, even in doses that were 1 to 2 milligrams per kilo in patients that were in those states where we call them depleted catecholamine states. And we have to understand that really the sexiness in ketamine early on was that it blocks muscarinic and nicotinic receptors. Those are parasympathetic receptors, and by doing that, it optimizes that sympathetic nervous system, gives us maybe a little bump in blood pressure, a little bump in heart rate, and allows us really the comfort, or it was perceived comfort, in maybe inducting these patients in those low perfusion states. But we have to remember that in catecholamine depleted states, these patients are really at death's door. And we have to be very, very careful. This goes all the way back to other podcasts we've done looking at airway management. And we did a podcast specifically on resuscitative advanced airway management, slowing down, doing the little things really well. This is counterintuitive to the mechanism of action that we often teach with ketamine. With the ability to block those parasympathetic receptors, we automatically think that we're going to have a positive response. We're going to see that blood pressure climb, that heart rate increase. That's going to buy us a little bit of time. But again, because of the catecholamine depleted states, oftentimes they are already maxed out, and they are not even able to handle that increase in sympathetic response. And that actually puts them over the edge, and we see a dramatic reduction in hemodynamic response in those cases and hypoxia. So I think it goes back to a medication is not going to fix an issue. We have to think critically. We have to slow down. We have to go back to our basics. We have to resuscitate our patients, go back and use good airway management skills, look at the Heaven criteria, identify areas of concern. Again, I've talked about the Heaven criteria in other podcasts. It's become a standard of care around the world in airway management, as far as how difficult potentially that airway is going to be, and guiding your thought process from a DL/VL standpoint. I've always said to the authors, Dave Olvera, Dan Davis, that I felt like it was more so a tool for me to look at from a resuscitative side. If I identify my patient is already hypoxic, I'm going to fix that issue. If I have a patient that is sanguinating, if they are in a state of hemorrhage, we're obviously going to fix those life threats. We're going to resuscitate with volume, preferably blood products if possible. And so I think from that standpoint, we have to go back and we have to do the things that are going to make the biggest difference. A medication, again, is a choice. And so what do we take from this? I think this is just a reminder. This is a small sample size, really 130 patients is all they were able to do based on exclusion criteria. The training of the providers from this data, right? They looked at multiple services, ground and air, and so we know that the training could be different. Protocols are slightly different. Paralytic use is also something that we could look at and say, hey, did that factor into that hypotension or that hypoxia? And really, from the standpoint of looking at ketamine use, we have identified a few years ago that looking at shock index should be our key indicator in lowering that dose. We know a high shock index greater than 0.9 is an indication of a high potential mortality. Those patients are not going to do very well. And so we have taught and been teaching that we want to lower that dose, bring it down to a 1 milligram per kilo dose, or even 3/4, 0.75 milligrams per kilo in those catecholamine depleted potential states. And those are those high shock index patients. So I think we have to go back, evaluate every patient that you're going to RSI with a shock index evaluation, resuscitate them, thoroughly evaluate that airway from a standpoint of difficulty, not only from the DL versus VL thought process, but from how is the hypoxia, the extremes of size, how is this patient going to be able to be managed from an airway standpoint, and go through the entire Heaven criteria. Critical thinking is the key. And I've said this many, many times that critical thinking is the number one aspect of rapid sequence intubation. When we train, it is all about that. And that's where you cannot be black or white. I did a podcast on this. You cannot be black and white. You cannot have that mindset. I think many of us are black and white in different aspects of our life. But really, to be a good critical thinker, you have to have those 50 shades of gray. You have to think broadly, objectively, have a wide perspective, and understand that a medication is only as good as the person administering it and your understanding of what's going on. So I hope that this quick podcast was beneficial. I will put this paper in the show notes. If you have any questions, please email me at eric.bauer@FlightBridgeED.com, and I will talk to you soon.
The FlightBridgeED Air and Surface Transport Symposium Series changed the rules for EMS conferences.
Fast 21 Virtual will be no different.
This year's program will take place May 11th and 12th, 2021. And while we all can't get together, believe me when I tell you, we are working hard to make it feel like you are there. Go to fastsymposium.com for more information and to get your Fast Pass now.